I want to at least give you guys just both open mic as the kind of like set the table about HCC and just like introduce the topic to the audience, and then we'll jump into like the real meat and potatoes of it. Richard, do you want to start?
Yeah, sure. I mean, from the oncology standpoint, liver cancer is fairly unique. We know what causes it. Chronic liver disease in 90% of patients, where most cancers we don't. And I sometimes make parallels to lung cancer because it's a malignancy that's occurring in a very critical organ, right? And usually that organ is sick. In the context of lung cancer, it's COPD and lung disease. In the setting of liver cancer, it's cirrhosis. And how we approach patients is really not only dictated by the tumor characteristics, but the characteristics of the patient and their underlying physiology. Very different to have a 2-centimeter tumor in someone who is well compensated, Child-Pugh A, no portal hypertension, as compared to someone with a 2-centimeter tumor with a bilirubin of 8, renal failure, and bedbound, right? I mean, two very different scenarios, and by the TNM staging system, they're the same, right? Stage 1 tumor. But obviously their prognosis is very different, and that's where a system like TNM fails our patients with liver cancer, because it ignores this fundamental underlying risk of outcome and death, which is their liver function. And so that is why I think largely the Barcelona system has been adopted. There's many very good staging systems globally. In the modern age, most of them try to capture the liver function as well as tumor characteristics, and it has served to be prognostic for its various stages, and it really has been the backbone for clinical drug development and clinical trials, so we can all speak the same language across disciplines and across regions. I could go on for an hour, but I'll let Julius chime in as well.
All right, Joyce.
Yeah, definitely second all these comments from Master. I will say, from a radiological perspective, liver cancer is a bit unique in that it's one of the very few cancers that can actually be diagnosed in non-invasive fashion. And in my view, this comes both as a blessing as well as a curse, because as a scientist, I always want tissue, and I want to sort of understand biology of a tumor, and liver cancer is extremely heterogeneous because it's very poorly understood in terms of his molecular bioprofile, mutational map, and so because it has been diagnosed using LIRADs in these patients, and because we were blessed to have amazing diagnostic tools like the MRI and like triphasic CT, that in many of these cancers gives us the diagnosis just by imaging features. At the same time, we've, I think, for a long time missed an opportunity to understand these cancers and to map them out with retrospective and sometimes even prospective data from a biological and pathological perspective. And so IR has, once again, a very, very important role here, not only from the side of local regional therapies, where, of course, we're represented, but also from obtaining samples, I think. And I think this conversation is picking up a lot right now in light of the so many upcoming drugs and trials.
Mm-hmm. Well said. All right, so I just want to talk about some boring stuff first, but feel like kind of a little bit necessary. And Richard, we'll kick it over to you. I kind of want to know, like in the UCLC system, particularly with your practice, what are the referral patterns for HCC? Like how do they get plugged in with oncology?
Yeah, that's a very good question. And look, I'm at a large tertiary center, and I've been here a while. And, I'd say historically, and probably still, the backbone of a successful program is going to be driven by transplant. And that puts you on the map, really, because that is the backbone of cure. And when I say transplant, often that's associated with hepatobiliary surgery. But the reality is most patients are not going to be surgical candidates. At a large health system, we control a lot of patients because they're part of UCLA Health, and they get referred in either to hepatology with a liver mass. Some of them will be referred from hepatology to then the liver cancer center, and I'm part of that. At the same time they see me, they might see the surgeon, or maybe they'll just see me first. And I'll let Julius speak to this, and I'm speaking a little bit for my IR colleagues at UCLA. I mean, they have a big presence, and they probably get direct referrals themselves from outside UCLA and within. But I think most of the referral pattern comes through internal medicine in some way, whether hepatology or directly to oncology. Surgery will see patients, and unless they're directly a resection candidate, which few are in the US because our patients generally have some degree of portal hypertension from Hep C or metabolic liver disease, NASH, MASH, unlike the East where hepatitis B dominates, and those patients are not as cirrhotic and they do have more resections. But, patients will come in, they can't get a transplant right away. And as part of their evaluation, they see medical oncology or the liver cancer program to help manage them while they're waiting for transplant, right? And also weigh in on their candidacy. In my practice, are involved with patients of all stages. That's different than in the community where someone with liver cancer might just see the oncologist when they have metastatic disease, or they're not part of a very active multidisciplinary program. Things are fractured a little bit more in the community, and maybe the hepatologist might send someone to IR, and when IR is done, send them back to hepatology or oncology, and it's a little less organized. But at our center, I'm seeing patients direct referrals to me because I'm known in the community, in the cancer community, direct referrals to hepatology, and then to me, or even from surgery.